Croeso, welcome. So for this talk I'm going to take you through how I would go about interpreting a CT head scan. What we'll do first of all though is we'll start by going through a little bit of history, and some of the content in this subsection will have already covered some of this, but I just want, for recap purposes, to just go through it again briefly. We'll go through some principles about CT scanning, and then we'll do some interpretation. Okay. So first of all, you'll see on screen this is the first prototype CT scan. It was originally built by EMI and Godfrey Hounsfield, who was the scientist who was heavily involved in developing it. There were other prominent physicists working in the field across the globe, but Godfrey Hounsfield is the one who is most commonly associated with the creation of the CT scan. He used some mathematical theories from Johann Radon and Stefan Katzmarz in order to develop this technology, and it's now widely used worldwide for diagnostics. The first time we ever saw the inside of a head was in October 1st, 1971, when Atkinson Morley was investigated for what was thought to have had a brain tumour. So what is the principle of the CT scanner? So it's a diagnostic procedure. It uses X-rays to build a cross-sectional image of the body. It's based on the principle that the density of tissue affects the passage of an X-ray through the object, and therefore it takes longer for X-rays to pass through more dense objects than through less dense objects, and therefore when the detector is receiving those X-ray images, it is not only detecting that the X-ray has reached it, but how long after the transmission point did it reach it, to therefore use as a surrogate of density. The emitter in a CT scan, different to an X-ray, as in a plain film X-ray, the emitter will rotate around the patient, and that will be emitting X-rays at all times, and is the form of a beam. The detector is on the diametric opposite side of the patient and moves in synchrony with the beam. It takes readings from a section from different angles and allows the depth of the object to be appreciated, therefore allowing us to understand how thick something is, as well as what its cross-sectional shape would be. And these readings allow the density of the material to be determined, as I've already said. We've already talked in a prior session about Hounsfield units, so I won't go over that again today, but you can see at the bottom a graphical representation of how the density of the object is transmitted into, or converted, into a colour for the pixel of the CT, with air being black and cortical bone being white. Radiation is an interesting conversation topic with regards to CT head scans. People get very frightened about the amount of radiation exposure from a CT scan, but actually if you look at the amount of X-rays, it's 1 to 2 sieverts, and the annual background radiation received is 2.4 sieverts. Now, in isolation, one CT scan therefore isn't a significant increase in radiation exposure. It's about an extra 1 year's worth of radiation exposure. But if you have multiple CT scans, then it does obviously significantly increase the amount of radiation exposure that person has received, and there have been linked reports of people having too much radiation exposure having an increased rate of cancers and other pathologies. So we have to be absolutely careful how often we undertake these. And probably the bit that's relevant for context is that if you look at a chest X-ray on the screen there, it's 0.02 sieverts, so you're giving a lot of X-rays, as in a lot of chest X-rays, of a person in terms of radiation dose when you're performing a CT scan. And we talked in the prior session about pixels and voxels, and it's important, as I said previously, to think about it as being a square matrix of those pixels. They are usually 512 by 512 in size, therefore that's 262,144 pixels per slice, and we talked previously about the number of slices, or the thickness of the slices. So if you're trying to visualize an image, the thinner the slice, the more layers, and therefore more pixels. So it's almost too much data if you go too thin with too many layers for the person to interpret when they're looking at that scan. What I'm going to try and do now is take you through how I would interpret a CT scan, and I think it's important to think about how I look at the scan. I'm not going to do a full sequence, and again, I'm not a radiologist, I'm a stroke physician, so this is how I would go about looking at a scan in, say, a clinic or in an on-call setting when trying to work out if somebody had a stroke. At the same time, there are parallels in how what I would be doing and what a neuroradiologist would do. But one of the key bits you might notice when I'm going through the scan is that I'm not actually just looking at one layer and then moving on to the next in sequence. I'm sometimes actually going in between and going back and forth a little bit to see how those images change. I've tried to simulate as best I can with a PowerPoint, so if it doesn't quite work, please accept my apologies. These are widely available CT images online. They aren't patients, but they are anonymized. So this isn't somebody you should know, and the permission was given for those images to be displayed on the internet free of charge. So first things first, to orientate yourself. So when you're looking at the screen at the moment, what you're seeing at the top of the image is the nose of the individual by here. This is the left-hand side of the person, and this is the right-hand side of the person, so it is an alternate to what you would be expecting when looking at the image. And what you need to think about is that that person is lying in front of you and you're looking at them from below. So technically the top of their head is behind the computer screen, their feet are in front of you, and you're looking up from the base of the head, so you're looking up in that direction. Now, what we're going to be doing is travelling from here upwards, but point of note is that the image is actually taken in that sort of angulation because we're trying to avoid as much as possible the delicate organs. So therefore what you'll see is that we'll be travelling up in that sort of direction, and each CT scan is taken at a slightly different angle depending on the individual's head shape, so therefore there will be some variation from person to person, but grossly these are relatively similar. What you'll see here is the sinuses, which are the black objects. This is the left ear and this is the right ear. This is the vertebra at the top of the spine, and here you'll see the top of the spinal cord with the CSF surrounding it. You can just about see the vertebral arteries coming in here, and this is your nasal cavity. So as we head upwards, and again we're moving in that direction, so from the base, you'll start to see the cerebellum coming in, and you'll start to see the base of the eyes. This is the left eye and the right eye, and the nose is just at the top there. This is the brainstem coming in, and this is the pontine area. This is the base of the cerebellum. We've got some temporal lobe coming in here, and you can definitely see those eyes. We are jumping a little bit. This isn't a full set of CT images. I've taken just about 15 to 20 slices just to give you a flavour of what it's like to interpret a scan. The basilar artery is about to form. It's not quite there yet, but this cerebellum's nice and healthy. The CSF space here is appropriate, and there's the fourth ventricle, and that looks nicely positioned and filled. We've now got the top of the eyeball, sinuses still. We've also now got more of the cerebellum visible, brainstem here, so this is the midbrain area, and that temporal lobe is really becoming quite evident. Here we've got the middle cerebral artery on the left-hand side, and on the left-hand side this is a contrasted scan. I didn't intend to get a CT that was contrast enhanced, but you can quite clearly see the middle cerebral artery here on the left and on the right. The CSF spaces here are appropriate and filled as you'd imagine. The skull is quite evident on the outside here, and you can see it nice and white and dense, and you can see this greyness here in the brain tissue. Here's your MCA again on your right hand side. You can see it curving around. This is where this is essentially the M2 branch coming off, and this is the M1 branch. So we've got M2 here, M1 by here, that angulation. The anterior cerebral artery will have branched off going forwards just below this, and we can't quite see that on these scans at the moment, but we can see here that that MCA is looking nice and healthy and flowing well, and the same on the left hand side. The brainstem area is all starting to disappear at this stage, so what you'd imagine. Here's the more healthy brain tissue coming in. The more traditional cerebrum coming in from on both sides. We've got the start of the ventricle. You can start to see the C shape of the ventricle on the lateral ventricle on the right hand side and on the left hand side as well. You can see on this person that there's actually very little CSF space on the outside. This is quite a young person based on this. I would imagine this person is a young adult, so probably between the ages of about 20 and probably up to about 40, 50. You'll find that after that sort of age, the CSF space on the outside of the brain tissue will start to become a little bit more prominent as the brain tissue naturally goes through its evolution and starts to shrink slightly. By the time the person reaches about 80, you'd expect to see a good sort of 5 mils worth of CSF at the edge of the brain tissue. But at the moment, that's a healthy, fully filling brain, so that's not of any concern. Ventricles progressing, you get again larger here, the lateral ones. So you've got 2 lateral ventricles, as I've already alluded to. There's this little C shape or banana shape on the side. And then if we go a little bit higher again, this is a key area for the stroke physician, because if you look at this region, we've got the thalamus, as we've discussed previously, we've got our ventricles, we've got our frontal lobe, we've got our parietal lobe, we've got our occipital lobe. So this slice alone would be quite a good place to go to for a lot of lobe pathologies, but you couldn't just look at one slice, you need to look at all of them in unison. But one thing I wanted to draw your attention to is if you look here, if you follow the cursor, you'll see that there's a very thin line on the outside here. There's a little white line, and that's the cortex of the brain tissue. So that's where you would expect all of the higher density neurons to be. That's where a lot of cortical function is preserved, so language, calculation. In your subcortical area, a lot more motor control and transmission of signals. So what you're looking for is a nice healthy border on the outside here, and this all looks appropriate in this individual. And the thalamus here, which is posteriorly supplied from a blood supply perspective, all seems to be intact on both sides as well. And you've got your insular cortex, not visible yet, not visible in these slices as well because this person's a bit younger, but it'll be in this sort of region, which is like a little snake-like appearance. And then you've got your caudate head and basal ganglia in this region as well. So if we keep progressing upwards, all that looks nice and healthy. You can start to see as you get to the crown of the head now, there's a bit more CSF space on the outside, and that all looks appropriate. So that it would be my way of starting to progress through a CT scan. These are going to be probably about 2.5 mil slices. I'd be looking to look at the 0.625s for or thinner slices for the arteries, so look in more detail, and I'd be looking at the 5 mil slices usually for brain tissue, and 2.5 mil slices I'd be looking at the brain tissue. But again, each clinician has a slight variation on that, and there are good logics for using different slices for different objects you're looking for. So that always worth having a structure, and I remember when I first started looking at CT scans, I didn't really have a clue what I was looking at, and I missed so many different things. And it was only when a colleague of mine suggested looking in a very structured way that things became a lot more clear. I use a slightly different mnemonic to the one that's on the screen, but I quite like this one for somebody starting out now. I think if I'd gone back, I would have taught myself this one if that was possible. So I would suggest using blood, cystins, brain, ventricles, bone, and to remember that you can go blood can be very bad, which is very true. So using that approach, you can look at all of these different findings, interpret them in a systematic way, and ensure that you reduce the risk of missing anything of key importance. Most important though is to not get sidetracked by something glaringly obvious in the ventricles when you're trying to look at cystins, or missing a brain problem because you're diving ahead to a fractured skull. Always make sure you do it in this order and get into that habit of ensuring that you don't change your pattern. So just to show you some of the basic abnormalities I expect you to sort of see on a CT scan. This is not an exhaustive list. There's clearly far more abnormalities to find on imaging, but for you as a beginner, I think this is probably a good starting point. So the first thing to look at is this is an extradural hematoma, and you can see in this individual they've actually had a fractured skull, and outside of the dura mater, so the protective layer around the brain, they've got a collection of blood, and that's pushing into the brain like pressure on the brain tissue, and that's therefore extradural. Subdural tends to be more like a crescent moon. It's sort of more continually spreads around the brain. It can actually push the brain quite significantly, and in this instance has actually got a focal area of pressure pushing on the brain tissue, they're normally more smooth, and you don't tend to get this level of inpouching here. So a normal kind of thin sliver on the outside, what you expect to see with a subdural hematoma. The one that tends to be more spontaneous rather than trauma-related is a subarachnoid hemorrhage. This is usually when you have a ruptured aneurysm, say, for example, and this is actually showing you the blood specifically in the ventricle, sorry, in the cistern spaces here, but it's a graphical way of demonstrating that the blood is actually within the brain now, so not just on the surface of the brain, actually physically within the brain tissue territory, but not within the brain. And that's kind of the thing to think about with all these blood kind of abnormalities, is that you've got the outside of the protective film, in between the protective films, your subdural, but it's outside of the arachnoid mater. And then you've got your subarachnoid, and that then slivers in between all the brain tissue, but it's not physically within the brain itself. When it gets in the brain, it looks more like this, and that's when you have your intracerebral hemorrhages, so intracerebral, so inside the brain. There's three on the screen there. The one on the far left here is looking very hypertensive to me. These deep soil hemorrhages tend to be because of a burst blood vessel from a hypertensive problem. Can be aneurysmal, but it's usually hypertensive. These lobar ones are more likely aneurysmal. This is the center image, and they tend to be either post-infarct as well. This one is not post-infarct because we know that you get a particular shape in that instance, or it could be related to a condition called cerebral amyloid angiopathy, which is when you have slightly more fragile blood vessels. And the mixed density on the side here could be due to this being a slightly delayed scan, so a few days after the original event, or it could be due to somebody having an anticoagulant on board. It could be post-infarct, and to be honest, this looks a bit more post-infarct to me, because you've got almost this wedge-like shape, so it's like a little triangle, like a pizza shape coming out from the side there. So that to me looks a bit more suggestive of a mixed density hemorrhage related to an infarct, so an oozing blood vessel at the time of an infarct. And that's not the standard size you tend to see. You tend to get a little sliver, a tiny little amount of blood in most infarcts. This is obviously a bit more dramatic. Cisterns are next in our acronym, so blood can, so cisterns, bad. Can be very bad. There are 4 key cisterns that should be assessed for, which is the suprasellar cister, as you can see in the centre there, the ambient cistern posteriorly here, the fourth ventricle, not formally a cistern, but it is classified in the cisterns, and that's what I showed you as we were going through the scans, and then the Sylvian fissure here on this image on the right hand side, but they are on both sides of the brain. So central, 2 lateralizing ambient cisterns, 2 Sylvian cisterns, and a fourth ventricle. And you're looking for them being effaced, so squeezed, blood being in them, or them being asymmetrical for any reason, which might be due to the brain tissue squeezing on them because it's swelling for some reason. Then you've got sulcal effacement when you're looking at the brain. So this is our next sort of category, which is brain interpretation. So it's taken us this long just to get a brain analysis. This is when you see a slightly older brain. This is what I was talking about, a bit more CSF on the outside. You can see these little infolds, little fingers coming in. These are the sulci of the brain surface, and its effacement of these, so when they have been smoothed out, suggests that the brain is swelling within. So that can be due to infarct, or it can be due to a tumour, say, for example, but it's when you can't see that kind of that as prominent an infolding as on the other side, such as on this scan, where you've got quite a large infolding here. Oh, there's got a slight bit there, isn't it? And quite a large bit here, and again quite small. So this suggests this area is infarcted, and in fact, if we go a little bit further in our analysis, you can see here there's a slight sliver of brain tissue with your cortex intact, but this looks a bit more diffuse and a bit more generally grey, and that suggests that this is swelling due to most likely an infarct in this region. And due to the fact that this is preserved in this area, I would suggest that this is a middle cerebral artery infarct on the right hand side, and that your left MCA territory is preserved, your occipital lobe, therefore your posterior cerebral artery is preserved, and I think probably their anterior cerebral artery is preserved in this scan as well. So it's just this MCA territory that's affected. And that grey-white matter differentiation that I was alluding to is what we're looking for in most of these early infarct signs. So you can see here on this scan, nice clear little cortex, and then you've got very grey diffuse here, and that shows that there's edema present, suggesting that there is brain tissue damage, and it's usually due to hypoxic brain injury, infarction, tumour, or a cerebral abscess. You're also looking for abnormal shifts of brain tissue. So on this side, you can see that the brain is pushing over to the patient's left-hand side, to the right side of the image, because there's something wrong on the right side of the brain. And to be honest, that probably doesn't look fully like an infarct. This looks like there may be something like a tumour growing, because what you can see here is that ventricle on that right-hand side is definitely completely obliterated by the brain tissue squeezing on it and pushing it out of view. Next thing with the brain then is to look at hypodense foci, so that's edema or established infarct. So this is an infarct that may be at least 12 hours after, sometimes more like 24 hours. Really, you wouldn't start to see major change like that on the screen for about 3 days after an infarct, but edema from a tumour or an abscess can appear hypodense like this at any point during the course of its development. Hyperdense foci in the brain then could be blood, so actually, as we've seen, hemorrhages. It could be a thrombus in that middle cerebral artery, so this is not a contrasted scan. So in the last one we saw, all of the MCA were very clearly visible around that route. This is just visible here. That is a clot. That is a focus of blocked blood flow. That artery is occluded. That needs to be either dissolved or it needs to be removed by mechanisms to treat that stroke. Otherwise, the brain tissue supplied by this artery are going to be damaged. So this is a major M1 thrombus that needs to be removed. It can be calcification though as well. You can get little specks of white in the brain tissue that can be due to just calcification in the brain tissue, and it's also always worthwhile looking out for that. So next we move on to ventricles. We've covered a lot of this already, but you've got three main things to look for in ventricles. One is the intracerebral hemorrhage, again leaking from the brain tissue into the ventricle. So that's when you have like a thalamic bleed and the amount of blood is so great that it kind of seeps out and into the ventricle, and you can see that something like a layer at the back of the lateral ventricle. You've got your choroid plexus to look at, which is a completely normal finding. This is where you produce CSF from, and they become calcified over time. So when we talked about calcification in the brain tissue, this would be a prime sort of example of what calcification of normal brain tissue would look like. And that's not a pathology in this instance. This is a normal finding. And then you've got hydrocephalus, and you can see in this individual those ventricles are much, much larger than we've seen in all the other scans, and that's ventriculomegaly. It can be difficult to tell whether ventricles are enlarged in an older person because the brain may be just expanding because the brain tissue is shrinking generally, and therefore giving the ventricles more capacity to look bigger. But we know that in that individual that is definitely enlarged, and anything that looks that grossly enlarged would need to be investigated as a possible cause for symptoms, and therefore a non-stroke diagnosis. And then final one is bone, and what you can see on this scan here with this lovely red arrow showing us exactly where the problem is that there's a skull fracture here. And we do see these from time to time, people who've fallen after they've had a stroke, people who have actually fallen and had bleeding around the brain or in the brain as a result of the fall, so not actually a stroke at all. It's always worthwhile looking at all of these things, because if you miss something like a skull fracture, it can cause problems later on down the line. So it's always worthwhile looking for that, and you'd be surprised how often it might be present and might significantly alter your management plan for that patient. I've got some variations on screen here, so basically using the same technology, the same principles, but not the same interpretation of the images, same difficult approach to the way you look at them. We'll cover those in another talk in a different subsection, so don't worry, we'll come back to those briefly, and again that will just be a fly through, so don't worry too much about that. Thank you for listening. I hope that was helpful. The most important thing to to just bear in mind is that I've been looking at these scans for the best part of 10 years now, if not longer, and it takes a long time to get used to them. What I don't want you to take away from this talk is that you are now meant to be an expert on CT scanning. You're absolutely not. It's just to give you an idea of what we're looking for when we're looking at CT scans, and to give you some sense of what it means when we mention, or that finding we saw on this CT scan. You've got a bit more of an idea of what that might look like. I'd encourage you, if you are able in clinical practice to look at a CT scan of a patient, to do so and to try to see if you can tie together some of what you've learned to what those images show, and then how the patient has presented in front of you, because that tying of the three things together are vital in order to make sure that your knowledge of stroke and of any form of cerebral imaging can be consolidated. Thank you.